Welcome to our Global Health Crisis Reporting Forum. A few housekeeping matters before we begin. If you're on Facebook, search for the ICFJ Global Health Crisis Reporting Group. And if you're not on Facebook, please go to our COVID-19 resource page on icfj.org, where you can sign up for newsletters and register for upcoming webinars. As countries around the world begin to open up their economies, I better put my glasses on, during a pandemic, there's a huge debate about whether the resumption of business is coming at the expense of public health. And today we will speak with two experts, an economist and an epidemiologist, about what it takes to get it right and perhaps where we're getting it wrong. Dr. Martin Eichenbaum is the Charles Moscos Professor of Economics at Northwestern University, and he's the co-director of the Center for International Economics and Development, and his research focuses on macroeconomics, international economics, and monetary theory and policy. Dr. Tara Smith is a professor of epidemiology at the Kent State University College of Public Health. Dr. Smith's research generally focuses on infections transferred between animals and humans. And she was very instrumental in the MRSA, in figuring out associations with the MRSA strain. So I want to let our guests know that nearly 3,000 or more than 3,000 journalists have signed up for our forum. And I know that many of them are eager to hear about what you consider to be the responsible way to open up after this long and difficult lockdown. Journalists listening on Zoom, please type your questions on the chat icon below, and I will do my very best to ask them. Those of you on Facebook can write their questions below the video post, and I've already incorporated questions that were sent in prior to this discussion. Finally, this webinar will be recorded, and you can find it on ICFJ's YouTube channel. So let's begin. There's an inevitable trade-off as countries open up and we see higher rates of infection. So let's start with Dr. Smith. How do we minimize the risk of a coronavirus spread while we resume business activity?
Right. Well, that's the million-dollar question. And so what, of course, we have been discussing with everyone is that really, if possible, you don't change your behavior that much, so that you still stay inside, or at least stay at home. You don't go to restaurants when they're opened up. You still do your takeout. You wear masks. We are still looking on really good data for the kind of the cloth masks that people are making and using and buying from places versus the surgical masks, where we have more data, at least with other respiratory infections. But we think if pretty much everybody is using them, at least that should help mitigate some of the spread. And, you know, keep doing things that are relatively low risk, doing things outside without being in large groups, continuing to, you know, really just to, again, avoid some of those high risk areas. And of course, all that is predicated on the reopening, which I'm sure we're going to talk about what thoughts are on the timing of some of that as well.
Right. Dr. Eichenbaum, do you agree? Is that the best way to open up the economy and make sure people are healthy and safe?
Well, let me put it in a little bit broader perspective, perhaps, and then specialize. I think there's an inevitable trade-off between purely health-related issues and the size of the recession that goes with the epidemic. There's no way of completely avoiding that trade-off. We could all stay in our homes forever, and that would surely be the safest thing if we only were worried about health. And we all understand, scientists and economists, et cetera, that's just not feasible. So the question becomes, what are smart ways to minimize that trade-off? So I completely agree with Dr. Smith. If you're going to go out, for God's sakes, wear a mask. The question then becomes, in a broader context, what data do we look at when we allow people to go back to business? How does that get supplemented with testing and quarantining policies, which is, I'm sure, a topic we'll come back to.
Yes.
But there is this inevitable trade-off between the extent of the recession and the health concerns, and the critical question is how to intelligently balance those two.
There is a sense that we're losing the scientific message to the public now because everybody is so frustrated about being home and being isolated, being away from family. And at the same time, the CDC hasn't even distributed its solid recommendations yet. And so states are opening up regardless. How concerned are you? I mean, because as we said before this, we opened up this discussion, everybody's data-driven, science-driven. How big a problem is this if the scientific message is not exactly coming through?
Is that for me or?
Either one of you. Yeah, sure. You can, or Tara, either one.
Go ahead if you like. I got to start the last one.
Okay, go ahead.
Look, there's an incredible tension. Being isolated is obviously painful. Being unemployed is incredibly painful. It falls disproportionately on poor people, people of color, etc. So, the recessions are always regressive. And you add to that social isolation. This is hard, and we shouldn't kid ourselves about it. That's why I do think it is critical for government officials to convey data-driven messages, but in ways that recognize human frailty and the frustration that real people face when their businesses are going broke. It's a real problem for real people.
It is, but there also is this fear factor out there. We've got people who we're being told we're opening up, this is happening, and we have, if you look at the numbers or the polls, if they're correct, a large majority of the people aren't convinced that they should eat in a restaurant or go out in the public or, so what does it take? If you want business to really resume, you have to somehow mitigate the fear factor too.
I have my views about that. And, go ahead. I'm sorry.
What does it take to overcome that?
I think you have to deal with the actual health problem. I'm going to pivot to testing and quarantining just with this preface. The government can say it's okay to open up, but a lot of people, as you say, are quite rationally afraid to go to a restaurant. They're afraid to go to a concert, and we wouldn't want them to, right? I mean, they are not being silly. What would make them more comfortable? Well, for example, if we had massive testing and quarantining of infected people, if we had serious protection of our elderly, that would be good for the economy, because if I'm someone who's, say, 40, and I know that the government has done a good problem of testing and quarantining people, then I don't face as much of a danger when I go out to do the things that are good for the economy. No fancy talk in the world is ever going to get around dealing with the fundamentals of, I think, testing and quarantining, which is expensive, and we can come back to that. And I'm sure.
Let's probe that a little deeper. I mean, because I think everybody's talking about the necessity for testing, but I'm really a little bit unclear about what is the best way to test. What is that effective way to test? Are we saying we should test everybody in the country all the time because you could be asymptomatic one moment and not the other? What is the prescription for testing that's effective, that will bring down that fear factor?
Mm-hmm. Well, if I can start there. So what we have done historically for many outbreaks beyond just coronavirus is that we test individuals and then we do the contact tracing. So that's the big part of it, is that those individuals who test positive, you have public health professionals, or in this case, lots of volunteers that have already signed up across the country to do this, so that they will ask individuals, where did you go in the last maybe 36 hours or so? Who did you have contact with? What was the extent of that contact? So is this somebody that you saw for 5 minutes, or somebody that you were in a conversation with for 3 hours? So that is what we are looking to do with this test, trace, isolate. And so then, of course, those people who have been tested and have tested positive, those people would be asked to isolate in their homes, or in some cases elsewhere if home is not possible. Then you have those contacts, and again, especially those that had extensive exposure, that you would either ask to quarantine themselves, so they're healthy but exposed, they could be transmitting the virus before they become sick. So you either ask them to quarantine, or in some cases you use the power of the state to enforce that, so that those individuals would not be out, again, mixing with the general public. And so that's really where this mitigation comes in, is that you've reduced the number of people who are ill and out spreading the virus, and you reduce the people who are spreading the virus during that incubation period. So with really good testing, tracing, isolating programs, you can reduce the spread of that virus pretty significantly in the population. And that's what we have used, previously, whenever the United States has had a measles outbreak or things like that. So I think that's where we talk about making people safer, and that's why it would reduce the virus in the population, is because especially of the quarantining of those contacts.
Do we have the testing and contact tracing elements in place in the US?
It depends on where you are. Most places, no. And that was one of the big things about reopening, was that according to, there have been multiple policy papers out on kind of best practices for reopening, and almost no one is following those. So in theory, you should have at least 2 weeks of a decline in cases. That's almost nowhere. And then you should have testing, tracing, isolating set up. So here in Ohio, we're already starting to reopen. We already have businesses reopen. We're reopening salons very soon, and restaurants for in-house dining. You can do it outside, but in-house comes, I think, May 21st. But we don't have any of that set up. We still are one of the lowest in the nation per capita for testing. We still are mostly testing those who are very ill, and some of our healthcare workers and other first responders. So those people with mild illnesses who have been missed pretty much the whole epidemic, we still don't have tests for those. And so that's still going to be problematic if we would try to go to this test, trace, isolate tomorrow, because we just don't have adequate testing in place. And as I understand it, we are training some of the contact tracers, but even those are kind of in the early stages, but also still depend on testing. So some places like New York City have really ramped this up and have hired, I think, like 1,000 contact tracers or something like that, and they have better access to tests and have been seeing a decrease in cases. So so other places are more able to do this, but I think the vast majority of places out there do not have this in place yet.
Let me just put some numbers, because I agree. I have a different perspective, but I agree fundamentally with what you're saying. Suppose we invested $500 billion, and I'm picking that number randomly. How could you think about whether that was a high return or a low return? Well, Congress has already spent $2 trillion on relief. The Fed its balance sheet has gone from 4.5 trillion to 7.5 trillion. So we're talking about massive numbers to deal with the economy. If you invested $500 billion and you were able to test, let's say, a very large percent of the population as a routine matter, that would have terrific health consequences, but it would also allow everybody who tested, wasn't isolated, who wasn't quarantined, to get back to work and have the willingness to consume, the willingness to work. So the social rate of return, not narrowly defined as just health, although that's obviously critical, but inclusive of the economy, it would more than pay for itself, I believe. And we're seeing some of that in other countries, like Israel, which has a much more extensive testing and tracing program. Now, they may be releasing too quickly as well. I mean, I was just on the phone with some of them, but we are behind on testing and tracing, and that is a real policy failure.
Right. Two questions that come. I'd like you to get into Israel. Is there anything distinctive that they're doing that you think is, because I like to draw on good examples or lessons learned from other countries. Are they doing something that we should pay attention to in particular?
Well, I think they did two things. One is they were very early on testing and isolating. So they moved very, very quickly and very aggressively. And the other thing that they did, their infection rate is not so different from the rest of say, the United States, but their death rate is very, very low. So they were very good at protecting the elderly very early on and in a continued way. So they, we all understand that 35-year-old with no pre-existing conditions is a very different situation than a 70-year-old. Well, the Israelis recognize that and move very aggressively to protect the elderly.
Now, just so we can spell it out, what does protect the elderly mean?
They weren't allowed to leave the house, period.
Okay. And is that the way I want to go back to this other issue, but is that the way we should be thinking about protecting the elderly, which is anybody over a certain age group for the next whatever? We get a vaccine in 2 years, doesn't leave the house. Is that the solution for people 60 and up?
Well, I mean, I think more views on that, but I'm going to defer to Tara.
Dr. Smith, Tara, you want to tell us about that?
Yeah, well, I think that's part of, is this going over onto me when I'm speaking?
I hear you.
Okay. I think that's partly, an economic issue, to be honest. We still have a lot of people 65, 70 who are out working. So we talked about some of those people who are most vulnerable, including, people who are impoverished and have other health conditions, but a lot of those are essential workers. They're the people out in grocery stores. They're the people who are, working as janitors and other positions that are considered essential right now. So I think that would be a great idea in theory, but how are those people then going to survive? Because a lot of them have very minimal Social Security income or some kind of other source of income. And so a lot of them feel that they have to be out working right now. So I think other areas that have done this better, of course, have better social nets than we do, and have better programs that protect some of those vulnerable individuals that we are lacking in the United States. So that's a concern for me for some of this.
Are we?
I agree, but I think in this case, you can make a pure health-based case that were we to extend special benefits to people of a certain age or in certain risk categories right now, not as a permanent program, because that's a whole other debate and we don't have to get into red and blue state, but just as a health matter right now, that the return on that kind of investment is a very high number.
Mm-hmm.
It sounds to me that you're basically thinking we could have spent the money that has been pumped into the economy a lot better and a lot more thoughtfully than we have right now. That if we had invested maybe more in testing, if we had invested in protecting the elderly specifically, we would have had a better time or an easier time opening up without seeing another outbreak.
Look, if we had had that in place in the beginning, we would have never gotten the public as genuinely concerned and correctly concerned about risks of infection, and we wouldn't have had the size of recession that we had. Once we were in a situation where the people were panicked, the Fed had no choice. We don't want to have to get technical here, but this would have been much worse if the Fed hadn't acted very forcefully. The last thing we need on top of this is a banking crisis. The last thing we need is, mortgage crisis. So they stopped that. So once the horse was out of the barn, they didn't have much of a choice. But there's nothing every day that goes by where we're not investing in testing. This gets worse, and it's just both from an economic and a health perspective.
Is this an indication of a lack of a national policy? When we talk about other countries, they seem to have a policy, and we seem to have by allowing the governors to take over. It seems as if we have 50 policies.
The founders gave us a certain deck of cards to play with. So it's, whether this was President Obama or President Trump, I'm sure they would have been different and behaved differently, for better or for worse, without taking sides. But there really are limits to what the federal government can or cannot do. President Trump, if you recall, got a lot of criticism when he said, I get to decide this. And everybody pushed back and said, no, you don't. So we do have a legal structure. We do have constraints that Israel doesn't. Israel is just a different system.
Right.
But at the same time, I think we are looking for at least early on, we were looking to the federal government for that type of leadership that I think has been really kind of abdicated. In every many of us have done what we call tabletop exercises. So you sit down, you get a scenario where there's some kind of a pandemic. So what do you do? What supplies are missing? Who needs to coordinate things? And in everyone I've ever been a part of, you have at least, that some response from the federal government, who usually are, again, in that kind of coordinating role, putting out policies for other states, at least, to recommend that they follow, even if they choose not to do so. And I think that's one of the things we're really missing here. The CDC, have seen them in a very limited aspect since about February. The coordination of distribution of supplies among states has been, really just abysmal. You have states fighting amongst each other rather than having that coordinated response. So I think that is something that we really had expected the federal government to step in and do, and we just haven't seen with this response versus, even for Ebola, where we had a handful of cases in the United States and only 2 deaths compared to, what are we up to, 82,000 now. Obama appointed an Ebola czar and really had that effective coordination at the federal level in that case. So I think that has been something that has been really disappointing here.
Well, we did have it at one point with the vice president and the committee.
Right. But how effective that has been, I think, is problematic.
Let me go back to testing for a second, because where there is an agreement among both of you that testing is absolutely key to the getting it right and opening up safely. But we're in the global north, and we're struggling with testing and contact tracing, and we've got a lot of resources. I'm just wondering, as this increasingly hits the global south, what's the prognosis there? How worried are you about this? Because they don't have the same resources.
That's terrible. I mean, so let me expand it a little bit beyond testing. There's the testing, but there's just the medical facilities, right? So one of the reasons we imposed the shutdown initially was we were very afraid of overwhelming our health facilities, and then death rates go up dramatically when that's true. If you look at a country like Ecuador, the state of the health system is unfortunately not very good, and people are being buried on being left on the streets, et cetera, et cetera. So the short answer is, the first thing they have to worry about with resources is treating people. Then there's a second issue, and I actually do some work with the IMF and the World Bank. This is a central role for those institutions to help developing institutions deal with the kinds of investments they need. They don't have the money, right? Peru doesn't have the money, but the IMF, the World Bank, that's exactly what their role ought to be, in my view, right now.
Are they stepping up?
I think it's a slow process. I think the heart is in the right direction. It's a massive investment, not nearly as fast as I would like, but I think there's a desire to do it. But it's a cumbersome process. Multilateral organizations don't often move as fast as we want them to.
Did you have anything to add to that, Dr. Smith?
Yeah, no, I think I agree. I mean, we certainly are concerned in any area that is underserved for this, that really, because they do lack testing capacity, that we are not going to have any idea outside of those countries of the impact of what impact the virus is having there until you start to add up those deaths. And that's not what we want to see at all. We want to be able to control this through more mitigation policies and have some idea of those cases and the case count before you get to those fatality rates. So it definitely is very concerning in other areas when the United States is handling this relatively poorly. You look to other countries that are less affluent than we are and definitely have concern for those.
Yeah. Well, let's talk on the other hand about what are there other countries. We mentioned Israel. Is there anybody else getting it right? There have been people who've talked about Germany and Iceland and South Korea and New Zealand. I'm just wondering, when you think about, where are the great lessons to be learned from people who are figuring this out? What comes to mind?
Mm-hmm. Yeah, I mean, the one I definitely cite a lot is South Korea, because they were prepared for this because they already had an outbreak several years ago of MERS, of Middle East Respiratory Syndrome in their hospitals, the coronavirus very similar to the novel coronavirus, to SARS coronavirus 2. So they took that seriously and they ramped up their ability to develop these tests. Of course, we didn't, we had to develop a new test for this, but they did that really quickly. They distributed it very quickly. They had all the materials that are needed for this. So we have been here, running short on reagents, running short on swabs, running short on personal protective equipment to protect people who are doing that sampling. And South Korea really had workarounds for all of that. They had excellent capacity with their testing. They had capacity for personal protective equipment. And they even have, not only the drive-through testing, but some little like testing boxes where you're reducing any exposure to people doing those tests. So they had all of that in place, and they have really been able to keep their cases down, keep their deaths down. It has ticked up a little bit when they again also relaxed some things as we did, but even so, it's so small compared to our outbreak, and we really had cases at about the exact same time, and they've just been able to control theirs through largely that testing that we have not had here.
I have a question. Did you want to say something?
No, I was going to agree, but also to say that there are countries like Germany that have done relatively well. Mm-hmm. Again, very intelligent, smart containment, early intervention. So yeah, there are role models out there.
There's a question from the audience that's related to this, which is, what factors influence the current shortage of testing? Is it materials, production capacity, poor distribution? What is it that what are we getting wrong here?
Yeah, I would say all of that. So with the testing, it has been in some cases shortages of swabs. So with these swabs, because we're doing a nucleic acid test, you can't just use cotton swabs because cotton, of course, comes from plants and has its own DNA. It can mess up with some of these tests. So you have to have these kind of nylon polyester swabs that are typically used, and those can be in short supply. So in some cases, we've seen shortages of those specific swabs that they need to do these tests. Other times we've seen shortages of reagents. So you have to have a, kind of a chemical mixture to use in this amplification process. And if any one of those is running low, then you can't do the test. And then again, personal protective equipment for those people who are, taking the tests at clinics. You have to protect them as well from people that may be infected. So as we run low on that, you had some clinics shut down and refuse to even take samples because they weren't able to protect themselves. So we've seen a lot of all of this.
Is this because we don't have the domestic capacity to ramp up our production?
Right, and we are now, at least I know, one factory in the Cleveland area is ramping up swab capacity. But I think a lot of this, again in these tabletops we have done, you expected some of this to come from these national stockpiles, and either we didn't have those or they were not replaced recently enough so that what was in there was expired, couldn't be used. It just was not there when we needed it. So I think we had relied on that when we were thinking about pandemic planning, and that has just not been in place, and there have not been orders to some of these places to ramp up production from the federal government.
So I agree with all of that, and to say that, this was, I certainly have a lot of criticisms of this administration, but it goes back beyond that. Mm-hmm. You can't limit it to just this. What is also really true is we're getting really mixed messages out of the White House and other parts of the government. I mean, the president, and he has every right to do so, but he has expressed skepticism about masks. He's expressed skepticism about testing. And that's translated into not being a national priority, right? There are laws on the books where every McDonald's could be a distribution center for testing. He has the right to do that. He has chosen not to.
Do you think there's going to be a massive rethink of globalization as a result of this? Because people are going to say, why should our PPP be made in China and our swabs be made elsewhere? Or it's just a temporary...
I think there'll be a backlash. I just hope that it's not, again, if globalization helps many people and it hurts many people. Every time a poor family gets clothes for their kids, they're benefiting from globalization. But when an auto worker loses his or her job, so it's complicated.
It is.
And now you add the security aspect. We have to depend on other countries. We can't do this alone. We just can't produce everything in a bubble and pretend the rest of the world isn't there. Now, that said, you asked a political question, we probably will get some pushback and lashback against globalization.
Yeah. Let's go back to testing. I have a question from somebody named Amy Barr. How effective, wait, testing is the answer, but the question is how effective is the testing? And we just saw this example at the West Wing where people were testing positive after testing negative. We're hearing about 15% false positives or up to 48% false positives with tests. I mean, I think it's legitimate to ask, do we have the tests that are fast enough and accurate enough to deal with this pandemic?
I would say so. The test that they were using at the White House was one of the Abbott tests, and the rapid test that could be done in 15 minutes or so. And that's specifically why that was used, because the other tests that had been used really from the start do take time. They take at least 2 to 3 hours to do, and then of course if you have a backlog of these tests, which pretty much every place does, it really has been taking 5 or 6 days or more in some cases to get those results. So that has been problematic, and that's why some places have switched to this more rapid Abbott test. But as was noted in some of the news yesterday, it was missing, maybe up to half or so of those who were actually positive using another method. So that's obviously problematic. I think the problem is more that, again, it is missing some of those positives rather than having some false positives. I think that's less of an issue to tell people, you tested positive for this. If you're not, worst thing it's going to do is that you stay at home and isolate yourself. But if you're telling people that you're negative when you're actually positive, then you're probably out there still going about your business, potentially spreading this until you feel really ill, and then you would stay at home. So the tests are not perfect by any means. And again, we have lots of different tests out there. So in addition, there's the Abbott rapid test, and there's also kind of a more traditional test by Abbott that takes longer. There's a lot of other companies that are doing this, and then there's a lot of like academic labs and hospital labs that have created their own as well. So you can't just say, the test, because it's really a mixture of all of those that are being used out there, each with different sensitivity and specificity. So that's something that we really haven't reckoned with as well. Although again, I know Abbott is not really going to like the publicity they're getting over this, but they have said that one of the aspects of that is that when you take the sample, sometimes you would put it in a liquid to transport it to a laboratory, and the liquid that people initially were using, now they're saying that actually has reduced the sensitivity of the test. So they have recommended changes in that, and I don't know if that actually will change the sensitivity and will reduce some of those false negatives or not.
Mm-hmm. Let me just add that as the scientists help us decide which are the better tests, and as we ramp up the resources to deliver those best tests, we should never make the mistake of the perfect being the enemy of the good, right? So I'm happy to concede that, there are going to be type 1 and type 2 errors. That doesn't mean that you're not doing a whole lot of good by proceeding anyways. So that's an important thing to remember.
It is an important thing to remember. Maybe imperfect, but it's certainly better than not having any testing at all. I wanted to get to this issue of herd immunity because some people think it is the answer to opening up safely, if you can say that. Last week I interviewed the chief epidemiologist of Sweden, and no, he doesn't say herd immunity is the answer. He does say that right now 20 to 25% of Swedes are immune, whatever. We have to decide what immunity means, or if we know what immunity means, but have antibodies. And the neighboring Finland, if I'm not getting the facts wrong, has 1%. So if there is another outbreak, the Swedes will be able to weather it a lot better, even though they have a much higher death rate than their Nordic neighbors. Do you think herd immunity is the way to go? I mean, Paul Rand Paul actually who had the coronavirus, seemed to indicate that. So I'm just asking, that's probably a medical question more than an economic question, but I'm just like to hear your thoughts on it.
Yeah, well, I think it's a little bit of both because, of course, using that strategy also will affect, the economy, both short term and long term. But one, I would push back a little bit. I think, and I should have looked at this, I guess. There was a study out maybe yesterday or a day before that I don't think we have really good evidence that Sweden's immunity level is that high. And they've already, as you mentioned, have already seen, a considerable amount of deaths compared to others in their geographic area. So I'm very concerned with this herd immunity idea that, yes, you could get the epidemic over sooner, but it will be at a really great cost as far as the mortality in those countries that choose to use that. What I'm concerned about is that just may become the default here as we are reopening and as we get pushed back against staying home and social distancing, that if we have enough percentage of the country that believes that's the answer, that may be what we're pushed to. And I don't think we're anywhere close to there yet. According to most polls, it still shows about like 80% of the country really prefers to kind of stay, maybe not locked down, but at least some measures of suspension of some of the normal activities. But if this goes on too long, what are we going to do? How are people going to accept, test, trace, isolate? I don't think all of them realize that part of that comes with that quarantine of contacts. And that's something that I've been trying to get out there is that, just because we're reopening, it doesn't necessarily mean all of this is over and you can go about your business, and there might not be additional shutdowns, or again, you may have to undergo quarantine if you've been exposed to this. So I don't think that herd immunity is the right answer. But I also think we need to have good long-term policies and messaging about those to the general public so they understand that we may have to be in some type of mitigation, mindset for quite some time, either until we get a vaccine or until this does run through the community.
Let me just add to that. There's two caveats. One is medical, the other has to do with the notion of herd immunity. If we don't do testing and quarantining, and we just say we're going to have brute force containment, you would have to do it really basically forever, right? Unless you had a vaccine, because, if you don't have some notion of herd immunity and or vaccinations, you get rid of the social containment, your numbers are going to go back up again. So you really do have to have smart containment for this to be sustainable. We're just not going to have complete containment without a revolution indefinitely, right? That's just not possible.
Can you define your vision of smart containment for us?
Yeah, I think, well, this goes back to testing, that we have, this is, I'm not necessarily me, but Paul Romer, lots of people, that, you get tested, the population regularly.
The entire population.
Yes, it's just a matter of that's what we have to live with until my colleagues in various science departments come up with a vaccination or something like a vaccination. Pardon?
Dr. Smith, is that practical to be testing everybody all the time? I mean, is that realistic?
I don't think everybody, but I mean, yes, definitely that's what we want to go for, is to do that type of repeated wide scale testing, and then again, contact tracing and isolation and quarantine. I think that's the way we get out of this with the fewest amount of deaths, the least amount of disruption, and the most amount of kind of normality to some of this. But again, we are just really far from being able to do that as a country right now.
Yeah, that's a policy failure on our part. Let me just add one medical thing. I'm curious what Tara says. I've worked with some models in which we all take it as a given that if you recover from the infection, that you can't get infected again.
Mm-hmm.
That's not given.
Right. Yeah.
That's right. You don't know what immunity means,
right?
Pardon? Yeah, you could be immune for, 2 years. I think there was one medical study that suggested that was roughly the period. There's a lot of uncertainty about that number, so no one should panic, but it's a real possibility.
Yeah, absolutely. I mean, we're looking at, again, at other coronaviruses, which is all we have to do right now because, of course, we're not, we just can't fast forward the future and see how long immunity lasts to this novel one. It is short-lived. I mean, with a common cold coronaviruses, people can be reinfected within a year. With SARS, it looks like immunity does start to wane after about 1 to 3 years. So that's definitely a problem too. And I haven't seen any good explanation of how Sweden is accounting for that. If by the time it sweeps through their population, a significant amount may no longer be immune, may have waning immunity, or again, that immunity is not neutralizing. So it doesn't completely keep you from being infected, even if you have antibodies. So I think those are all definitely open questions right now.
Yeah, it's a good point. Some scientists are saying that this virus will come back in the fall and come back strong. We'll have a second wave. Do you think, given what we've been through since February, March, that we're better off? We can better handle the outbreak without doing what Martin just said, which is clamping down and shutting down the economy and going into mitigation again?
Yeah, and I don't know. I mean, I really hope, again, that we will have countrywide testing and tracing by that point. But again, that second wave, we don't know. That is predicated on influenza models, and coronavirus is not influenza. Influenza also, again, we tend to see those second waves or just waves in the fall in general of flu infections for a lot of reasons. One, because there is more transmission in children because they're back in school, and for influenza, children are one of the main drivers of infection. With coronavirus, kids are still an open question, and whether schools will be open in the fall is an open question. So, so I think there are just lots of big question marks about that potential fall wave. But I know people are thinking about ramping up for that. I hope we will be prepared in the eventuality that that would happen. And I hope we could do it again with a more surgical strike using testing and tracing in a more widespread manner rather than having to completely close everything down again. I think you would still have to limit large gatherings, but if we can, even keep other parts of this open, that would help, I think, a lot of people's, mental health and still protect their physical health.
I mean, not to be completely negative, we have learned some lessons. So, for example, there's a lot of evidence that the subway policy in New York actually turned out to be a catastrophe. So, initially, most folks won't know this, they really cut back on subway service. So what that meant was that the subways were really crowded. And there's a guy, Jeffrey Harris, who's done a bunch of, it's not controlled experiments, but looking at the correlations between how the subway, the connection between the subway and the actual spread of the virus. So next time we're going to know, what? Have more subways, not less subways. So people can so there are those sort of tactical victories that things that we've won. Hopefully the medical system will not be so overwhelmed. We'll have, not so, the great panic was that people would just be overwhelmed. Those are important, real victories, but they don't eliminate the possibility of a lot of disruption.
Right. Tara, you mentioned that you were particularly worried about rural communities. I want to get into some of the socioeconomic issues here, and I'll get back to Martin in a second. But can you tell us why?
Yeah, so rural communities had not gotten hit for the most part early on. Of course, there's lots of reason. They don't have a lot of international travel. Weren't a lot of the places that were hit early on. But now we're seeing these outbreaks in places that are major employers within rural areas. So prisons, we have a lot of federal prisons in our rural areas, and we're seeing large outbreaks in a lot of those facilities. Meatpacking plants, which are again a key community employer in many of these areas. And for various reasons, meatpacking plants are just a perfect way to spread this virus amongst their employees. And then nursing homes, nursing homes, of course, are a problem throughout the country, but in rural areas where you have a relatively small population, just a small number of deaths from those in nursing homes can put you at the top of the list per capita for coronavirus deaths in the United States. And I think what concerns me is that as these epidemics are happening in some of these hotspots, people still aren't taking this very seriously that I have seen. There's still, I think, a lot of denial about coronavirus severity in rural areas because they just haven't seen it. They're not like in New York City, where even if you haven't contracted coronavirus, you probably know someone who has, or maybe you know someone who's died. And in the rural areas, that is just much more spread out. And so I think it's easier to think of this as, it's a problem in the big cities, it's a problem for other people, but not me.
Mm-hmm.
And so I'm very concerned that as we get additional cases in these rural areas, one, they tend to be older, so they're at higher risk for serious infection. They tend to have more health issues, more likely to be obese, more likely to have diabetes and heart disease, and they tend to be underinsured or uninsured. So, I know with my kind of farmer family, they also tend not to want to go to see healthcare professionals. That's something for the weak. And so I'm concerned that also that there is that attitude that, you won't go to the doctor really until you're kind of on death's door. And by that point, we know that this can move very quickly, and there may not be a lot of things you can do to mitigate it. And then, of course, many rural hospitals have closed over the past decade. So you're lacking expertise, you're lacking facilities. Some places have to, are a 60 to 90-minute drive away to get to real high-level emergency care. So I think all of those are kind of this perfect storm that, when it hits some of these areas, they're really going to be severely affected.
Martin, you said that this disease, we know that the disease disproportionately affects minorities. Do you think it's going to be the same way with the recovery, that it's going to hurt minorities and women in this case? Because you when we talked before this discussion, you said it's always bad to be poor, but it's really bad to be poor in circumstances like this.
No, I think that's, yeah.
So I just wanted to elaborate on that.
So you can just look statistically who really suffers during sort of normal garden variety recessions. And it's always poor people that get the big hit, and minorities. So, African Americans are particularly sensitive, Hispanics. Okay, but this one is even worse than that. And why is that? Well, we're all doing this by Zoom. My son-in-law, who's an investment banker, is doing his stuff by Zoom. My daughter, who's a marketing executive, is doing stuff by Zoom. But if you're working in a grocery store, if you're a bus driver, if you're a cleaning person, you're really out there exposed. So either you were fired because there's no demand for your services, or you're getting sick. And so, in fact, if you look at the fatalities, if you look at the infection rates, and you correct for age, it's very much a poor person's epidemic. Other thing is, interestingly, most recessions, men suffer more than women. Why? Because they tend to be in jobs in manufacturing, very cyclical jobs. This recession is different. This is affecting industries where women are overrepresented, the service sector, the health sector, things of that nature. So women are really getting hurt this time relative to men, and poor people, as always. I do think after the recession, there's going to be a fundamental rethink about how we do business, right? So not to get boring or technical, but think about the demand for commercial real estate. A lot of businesses are finding out, hey, this Twitter announced today, they don't want anybody back in their office. They said we could do this stuff at home. Well, that's going to mean a lot of lost jobs, a lot of transformed jobs, because if you don't have people coming to city centers, all the restaurant workers, all of the cleaning people, there's a whole ecosystem that tends to be populated by people earning less who will have to will move into other industries. So I think it's going to be transformative for a lot of industries, and a lot of poor people will get hurt in that process.
That's fascinating. I want to, before get to a few more topics before we wrap up, especially schools, reopening schools. Martin, California state schools are unlikely to hold in-person classes in the fall. And what does it mean for the economy not to have universities back in classrooms?
You know, I think universities are going to contract generally. We were talking about this before we got on. My own view, not speaking for Northwestern, is universities have gotten a little bit fat and lazy, and we've strayed from our core mission of teaching people. So I know Northwestern is a wonderful place to be an undergraduate. I am personally not sure we need all of the wonderful dorm facilities and all of the wonderful football facilities, and you know that somebody's got to pay for that. We're in a good position. Others may close down. So there are many small liberal arts colleges that aren't going to make it through this. And so they tend to be in small towns, going back to some of Tara's concerns about regional, rural places. You know, they're the industry in that town. And if they go broke, that is a really catastrophic consequences for that community. You know, is Boston going to suffer because Harvard's on Zoom? No, they'll be fine. But will some small town in Ohio suffer if the local college goes broke? Yeah, it's going to be really bad.
Let's talk about, Tara, let's talk about K through 12. Should we open schools for that age group, even though it seems that they're not getting the disease in the same way adults are, without fully understanding the risks to children and whether they're carriers? You know, I'm sitting in New York where they're looking at this Kawasaki type disease where all this inflammation of the heart is happening to small children. How do you look at this as an epidemiologist?
Yeah, and that's been the $1 million question since the start of this, is what are the role of children in spreading this infection? You know, we do see that even with the Kawasaki associated illness, that overall children are less affected by symptoms from this, that they don't get sick as much, they don't get as severely ill as adults, even though it can make some of them very sick, and there have been some deaths. But the key question is do they transmit? And we've really been unable to get to a clear answer for that. There have been several studies that have been published, and they don't all find the same thing. And one of the problems with doing these studies right now is that it's really difficult to look at transmission from children when they're not in their normal ecosystem. You know, almost around the world, children have been pulled out of classes. And so we're looking to those few areas where children have continued to go to school for the really high quality studies. And we really haven't got those yet. So we will be looking to Denmark and Australia and of course Sweden as they do some really good longitudinal studies, doing sampling at multiple times of children, of their families, of teachers who are in contact with them, to really see what the role of kids are here in potentially spreading that virus to others. So far, it looks like they are not a huge driver of this epidemic. And if that's the case, then yes, we may be able to put them back in school in the fall. But again, then that comes, you know, with that potential increased risk of maybe Kawasaki disease. We're still looking closely at that. And then, you know, risk is not the same. You mentioned K through 12, but older teenagers do have some additional risk that, you know, kids under 10 maybe do not. So it's hard to look at this as you know, kind of one block of children when there are different risks at different ages as well. So it's still a really big, complex question that I don't think we have a great answer to yet.
I guess it's a lot of research before states decide to open up or send their kids back. Is the consensus between both of you that probably most or many universities will stay closed in the fall? I know that there are places that are worried about just all these students congregating in one small space, in dormitories. Some schools, I believe California State School said they looked at, you know, 20% option, but it wasn't financially feasible. So is it the sense that maybe there's a greater chance of K through 12 opening, but college is less likely?
You know, I think that's totally reasonable. I've worked my whole life not to be in administration of the university. So, you know, unfortunately, I don't have to make that decision. I just want to say one thing about this, about the K through 12. There's a health aspect, but again, there's an economic aspect.
Mm-hmm.
If we don't open up schools, how do we expect moms and dads to go back to work? Those are not unrelated issues, and I don't see much of a discussion about uh, uh, how do you help moms, and it's inevitably moms that bear the brunt of this for good or for bad. How do they go back to work if the kids are at home? So there's a real economic component to that as well.
Yeah.
Yeah, it's a good point. And with the universities, I think we're seeing a mix. We have seen some that are dedicated to saying that they're going to open in the fall. I mean, Purdue has been very explicit that they are coming back on ground in the fall. In Ohio, Ohio State, University of Toledo, Bowling Green State University, and some other smaller liberal arts schools have said they're going to have on-ground classes in the fall. And whether that will change over the summer as we see this, whatever happens with the developing epidemic as we reopen, who knows? But I think some of them have definitely said that they are planning to be back in class in the fall. So I think there's a mix between those that are being kind of conservative, like some of the California schools, and just calling it a day now and saying we're going to go online, and those that really are trying to do their best to open up in the fall.
I guess we'll know a little bit more about the K through 12 because we could see if people have summer camps or international students, go back in summer, we'll maybe have more data there.
Mm-hmm.
I'm not sure about universities, but yeah, it's a mixed bag, isn't it?
It is.
I wanted to ask a couple of scientific questions because they always come up, which is, are we going to be a little bit better off in a few months in the expectation that there'll be medicines, there'll be therapeutics to help combat the most severe symptoms of the virus? That's the first question. And the second question is about a vaccine. These are the two questions everybody asks. Mm-hmm. Everybody wants to know the time frame, what's a realistic time frame for a vaccine, and your personal opinion about when we will have a vaccine that can be widely distributed to populations around the world.
Mm-hmm. Yeah, I'll start with therapeutics because therapeutics in some ways are easier, especially that the ones that we're testing now, by and large, are already FDA approved. So we already know that they're relatively safe, and we know some of their side effects in populations. The challenge is finding ones that are effective, and that's hard for any virus. We really just don't have great therapeutics for most of the viral diseases that are out there. So I'm hopeful, but I'm really skeptical that we are going to have some kind of good therapeutic, especially by the fall. I don't know. I don't really see that happening for the drugs that are being tested now, at least the ones that have gotten a lot of attention. Again, the results are kind of marginal. They may be better if given very early in the infection, but then again, you have to have that testing tracing in place. And, some of them like remdesivir are intravenous. So how are you going to do that early in the infection if somebody only thinks they have a mild cold? How are you going to get them diagnosed and get them on an IV drug? It's difficult. So I think there's some reason for optimism there, but I think we should temper that a little bit and not see those as kind of a savior. With the vaccine, I know 12 to 18 months for whatever reason has emerged as this consensus or something, but I'm really skeptical about that as well. I mean, with previous vaccines, even those that where everything has seemed to kind of fall into place, 5 years is really about the shortest time frame. And I think with this, because we are ramping it up so much and we're testing, I mean, something like 80 to 90, maybe 100 candidates out there so far, we're throwing everything at this. So there, I think in some ways we can shorten that time frame just because we're looking at so many candidates, but you still have to do human testing. You still have to make sure that they are safe and effective. And that time frame really can't be compressed all that much. And then, of course, there's the aspect of manufacturing and distribution and just getting, all the United States population vaccinated, much less globally. So I know Bill Gates has mentioned that he is going to take some of the best candidates and just start factories to make those. Which is great. We have to have that idea in mind, but I still think that is something that's going to take more than 18 months, more than 2 years, I think. So So I'm very concerned about this idea that we can kind of warp speed this and get a new vaccine.
Yeah, because the quickest we've ever done a vaccine before is what, 4 or 5 years?
Yeah, exactly.
Yeah, but we haven't all, I don't know if we've had a global push the way we have right now, and the competition and the brain power all focused on this.
And we did a little bit with Ebola, but again, some of those candidates we already had on the shelves. They just hadn't really been able to have been kind of the final aspects of development and testing weren't there yet. So we were able to finish those during the West African outbreak and then deploy them during the outbreak currently in the DRC. So I think we had that as kind of a model, but again, I think those were a little bit more advanced than what we have now as far as coronavirus vaccine candidates.
Martin, let me ask you about whether you're worried about a weakened food supply chains and rising food prices. Is that, what are your thoughts on that? And are you worried about inflation?
So first, don't worry about inflation. Bond markets aren't worried about inflation. I'm not worried about inflation. With unemployment that may peak at 25%, don't worry about that. At least not for the next couple of years. So that's okay. Now, does that mean certain items won't go up in price? Absolutely. So meat is the obvious example. We've really have less meat being produced now because precisely of the sort of infection issues that we've been talking about. I think we'll be fine. I think there will be temporary difficulties. You won't be able to go to Wendy's and get exactly the hamburger you want, but I don't think anybody ought to be flipped out about that too much. But that doesn't mean we shouldn't be careful and we shouldn't do our safeguards. But I'm not overly concerned about that.
Okay, I'm going to ask each of you one final question, which is, what's your forecast now for the economy going forward? And what's your forecast for containing the disease?
Well, I'll start with containment because I can't really forecast on the economy. I am definitely concerned about containment. I think you're going to see disparities. I think you're going to see some places that do that really well, and some places where maybe you don't have Sweden at the state level, but where it's just not going to be contained very well, where you're lacking the resources, you're lacking the labor to do this, you're lacking potentially the will of the population to really do what is necessary to contain this. So I think you're really going to see a checkerboard across the United States of places that are doing this great and doing this poorly. And unfortunately, I think you're going to get some new sparks from some of the places that are doing this poorly as they travel to some of those other places.
So I think that the questions are linked, and I'll tell you what the consensus forecast is roughly for the economy now, maybe a little bit optimistic. When we first started this off, everybody was talking about V-shaped type recoveries. That was the buzzword in the Wall Street Journal. Nobody believes that for a moment anymore. We're talking almost surely of, this quarter is going to be catastrophic on an annualized basis. I think Goldman Sachs has us coming in at a 35% decline in GDP. Now that's annualized, so that doesn't mean it's going to actually decline over the year by that. If we decline by this much every quarter, as much as this quarter, it would be a 35% decline. We think it won't be as that bad in Q3 and Q4, but we're probably talking about the largest decline in GDP in the post-war era, 8, 9, 10% on the year. And then a slow recovery, but from a much lower base. So I think it's very challenging. The best way to deal with that problem, in my view, is to deal with the health crisis. We are not going to get back to normal with magic tricks of the Fed. The Fed can buy us time, and they've done a magnificent job. Fiscal policy can help. It can buy us time. We are not going to solve this until we solve the health problem.
Well, I think we have an agreement on that, and the agreement for definitely more testing if we want to deal with the health problem. So I want to thank you both so much for this really fascinating conversation. I learned a lot, and I'm sure the journalists who tuned in also did. I want to thank the audience for listening, and I want to remind those people who did participate or listen to the webinar to take our survey, and that your feedback is very important for us. We're able to improve every step of the way with the feedback. I will be having a webinar next week to talk about lessons learned from reporting on the pandemic. It's a discussion with a reporter from the South China Morning Post, Linda Liu, who is in Hong Kong, talking about the challenges of covering a pandemic in China. And I want to tell the reporters out there that you can feel free to use the quotes. We will have this on our YouTube channel, as you know, but we would appreciate it if you could link to the video if you're going to cite our story. So thank you all very, very much. It was, and I hope you do come back. We can maybe take another look at this in a few months, and we'd love to have the speakers come and help journalists around the world really understand how to get their heads around this. So thank you again.
Thank you.
Thank you. Stay safe.
You too.
Bye-bye.